Brachial Plexopathy and neuronal linkage. Brachial Plexopathy is a disorder of the intricate nerve network formed mainly by spinal roots C5 to T1, which connects the spinal cord with the shoulder, arm, forearm, and hand. When this network is compressed, stretched, inflamed, infiltrated, or traumatically damaged, the neuronal linkage between the central nervous system and the upper limbs begins to fail. Hi, my name is Dr. S, and today we're going to discuss brachial plexopathy and neuronal linkage. Brachial plexopathy is dysfunction or injury of brachial plexus. Common causes trauma, traction, compression, tumor, invasion, radiation injury, diabetes, or immune response. Key symptoms: shoulder, arm pain, weakness, numbness, tingling, reflex loss, muscle wasting, or paralysis. C5 to T1 route, that is very important. C5 is the cervical spinal nerve root, and T is the thoracic nerve root that leads to trunk, upper, middle, and lower, division, interior and posterior, and the cords involved are the lateral cords, posterior and medial cords. Branches, 5 major nerves are involved. Neuronal linkage, motor cortex leads to spinal cord and the brachial plexus root, C5 to T1, brachial plexus, and arm muscles. There are two roots. Descending motor command activates interior horn cells, and ascending sensory input returns to spinal cord and brain. These involve the motor fibers that causes movement, grip, posture. Sensory fibers, touch, pain, temperature. Autonomic fibers, sweating, and vessel tone. Mechanism: traction or stretch that leads to myelin damage, axonal tears, compression, tumor, ischemia, conduction block. That is the final common pathway. Inflammation, uveitis. Immune attack produces pain, edema, demyelination. Radiation and metabolic causes fibrosis, microvascular injury, reduced nerve conduction. Clinical pattern: upper trunk C5 to C6. As I already told you, C5, C6, C7, and C8 are involved. Uptype pattern: middle trunk, radial link deficit, C8 to T1, clunky type pattern. Diagnosis: history. If the patient has this history of trauma, surgery, radiopathy, diabetes, infection, that can be the cause of brachial plexopathy. Neuronal exam, power tone, reflex, dermatomes, myotomes, and provocative signs. These are the tests: EMG, ENCS, MRI, Plexus, and lab that includes the glucose testing, HbA1c, inflammatory markers, autoimmune or infection testing. Treatment: mostly the treatment that is provided to the patient is the NSAID, corticosteroids, and other anti-inflammatory therapy. These are the cause-specific care, rehabilitation of the patient, and surgery when needed. Prognosis involves neuropraxia, Axonotmesis, rupture or avulsion, inflammatory neuritis, and delayed degeneration leads to atrophy and contractures. The functions: early diagnosis plus rehabilitation is equal to better functional outcome, and that needs time. That is very important. Summary, that is schematic summary for you. These are the anatomy, which type of roots uh, are involved: neuronal linkage, spinal cord, ventral lobe, brachial plexus, peripheral nerves, and target organs. Common causes: trauma, birth injury, thoracic outlet, inflammation, tumor, diabetes. Clinical features: shoulder arm weakness, muscle atrophy, and these are the diagnosis pattern. Clinical exam: EMG, MRI, and ultrasound. The treatment or management involve the pain control through corticosteroids, NSAIDs. These are given to the patient. That is the graphical summary of the whole discussion that we proceed or we go through in future in detail. Thanks and regards. Kindly you could like and subscribe this channel for further discussion on neuronal diseases.